Let's talk about some of the finer details in the smaller steps of surgery. Anytime you're handling a cannula, I think it's important to keep a finger resting on the cannula itself, not just the syringe, as you see here in the lower right-hand corner of the screen. So we're injecting some phenylephrine and lidocaine to help with pupil expansion for the case, and now we're going to put in some viscoelastic. The cannula, even with the Luer locks, can be very secure, but it can also shoot off into the eye. That happens and has been reported in literature. It's happened here, and it can be very, very damaging. So again, going in with the viscoelastic, this time you clear the cannula anytime before you enter the eye, and you go across and fill with the viscoelastic. Your end point here is when you see that viscoelastic exiting the paracentesis. That means you've got a good fill. Now we're moving on to lens insertion. So we're going to go through the main wound this time, inserting our cohesive viscoelastic. I like to have a wave or a cushion of viscoelastic in front of the cannula before I advance further into the eye and fill the bag itself. And then as a bonus tip, I like to keep my second instrument in my hand through cortex removal just so I can hook the paracentesis, which gives me counter traction as I insert this lens. So a little wiggle gets you into the main wound, and then you can deliver the lens, keeping the eye in primary a little bit, in my opinion, less traumatically than a wound assist technique. So now moving on to wound hydration, again with the finger securing the cannula so it doesn't fly off into the eye. I like to hydrate the roof of the incision, so just kind of gently sweeping back and forth across here. You don't need to whiten the cornea very much to get a good seal, and we'll do the same with the paracentesis. I inject some BSS here to kind of flush out the anterior chamber, reveals any chips or viscoelastic that's left in the eye, and then we'll go in with our Vigamox to seal things up. Same thing in a different case. Here we're going in with the Fin-Lido, finger resting on the cannula. You don't have to insert the cannula very far. You can see the swirling currents in the AC, and it doesn't take the whole syringe worth of Fin-Lido to anesthetize the eye. Again, clearing the cannula before you go in, make sure you have no air bubbles, and we'll go in with the viscoelastic here as well. Sometimes when you struggle to get the cannula into the paracentesis, the temptation is to push harder, and that's almost never the right answer. Usually you're hung up on one of the either upper or lower lip of the wound, and you're better off just changing your trajectory. So now we are putting in viscoelastic after cortex removal. Again, fill from the wound before you go further into the eye, and make sure you actually fill the bag so that the lens has a good place to land. Again, with the finger resting on the cannula, making sure everything's nice and secure. And again, we're going to use that second instrument to hook the paracentesis, provide counter traction, and give the lens inserter just a little bit of a wiggle, and that'll get us into the main wound. As I deliver the lens, I'm initially pointing down towards the posterior capsule, and then once I get under that lip of the distal rexus, I'll kind of level off and let the lens deliver planar to the iris plane. This is a more recent video showing my preferred technique. Again, anesthetizing the eye. Don't have to go in too far. Don't have to dwell too long. And then we'll go to our viscoelastic. Here I'm using a dispersive agent, and you'll see as you start to push on the syringe, I'll get sort of these spaghetti strands. But as I reach across the eye and push a little harder, I start to backfill, and I get this wave of viscoelastic that exchanges the aqueous for visco. It forces the bubbles out of the wound, and it gives me a really nice fill. Now we're going to insert our viscoelastic for lens insertion. This time I'm going to go through the paracentesis, and I like this because it forces any fragments or chips that are stuck in the paracentesis to reveal themselves. And again, we advance from a cushion of viscoelastic before advancing further into the eye. And again, hooking the paracentesis, wiggling the lens into position. Once you get it past that internal os of the wound, you know that you've got enough clearance to deliver the lens. And as the lens comes out of the injector, I'm just going to use that plunger to sort of nudge the lens down into the bag and make sure it seats nicely as it unfolds. Sometimes it's necessary to inject from the left hand while the INA handpiece or other instrument is still in the right hand. Here you can see I'm testing the cannula outside the eye because I can't have that finger on there for security, so I blast it before I go in the eye to make sure that cannula's on tight. I've got my index finger on the plunger, my syringe grasped between the thumb and middle finger, and then my ring and pinky finger resting on the forehead of the patient. So I can inject my BSS and then come out on position 0 with the INA handpiece. And that maintains chamber stability and prevents the AC from collapsing. You would do the same thing with viscoelastic in cases of posterior capsule rupture. Now I'm going to hydrate this wound in one pass. You see that I engage the corner of the wound right here, and I pivot with the elbow of the cannula resting against the sclera, and I just whiten as I go across in one smooth pass. It's a more efficient technique that I like really well. And we'll do the same thing here at the paracentesis. Make sure that that lens is well positioned. Just nudge it with the cannula. It's very safe. And then as I come out, I'm going to hydrate this paracentesis just the same.